Hello, I'm Ileana Piña. I am a clinical professor of medicine at Central Michigan, and this is my blog. And I'm really pleased today to have with me a good friend, Andrew Coates, who is the current president of the Heart Failure Association of the ESC, or the European Society of Cardiology, having their meeting this last week. Very exciting, part virtual, part in person. And Andrew had been the dean of the medical school, and he's now the dean of the College of Physicians, and spends his time in between Australia and the UK, which is a long way to travel each time. But Andrew, thank you for joining me, and thank you for being here with us today. My first question is, tell the audience a little bit about the HFA.
Great to be with you, and fantastic you're doing the blog. The HFA is the major heart failure grouping around the European countries. As you know, ESC is a composite of a lot of national societies. It's actually got 47 country members. Now, of course, countries in Europe, some of them are quite small, but some of them very big. So it actually straddles everywhere from the west of Ireland through to near the Japanese coast in Vladivostok, the other end of Russia, terms of the affiliated countries, and covers some of North Africa. So it's a very large geographical footprint. And the ESC has about 110,000 members for all of cardiology. But there are a number of associations, which are subspecialist groups that have a degree of functional independence. They're the area where subspecialists in rhythm disorders or in imaging meet together, and HFA is one of those. So we're not an independent legal entity, but we are a specialist group of heart failure physicians, but also nurses and allied health personnel from the 57 countries affiliated with the ESC.
So Andrew, the HFSA is probably the most similar to yours. What projects have you done together now with HFSA?
Yeah, HFA and HFSA, a bit of a mouthful to say, but we're increasingly doing work together, and it's a very pleasing collaboration. So we're doing things like we actually have a three-way partnership with our two organizations and also the Japanese Heart Failure Society, where we meet once a year and work on a particular issue, and that leads to a position paper. So we're into our third year, and we've done one on myocardial biopsies, endomyocardial biopsies, and an important one that I know you're very active in that's the universal definition of heart failure paper.
So how do you think that universal definition of heart failure is different than what the others have been? I mean, we've been hearing about, the inability of the heart to pump, blah, blah, blah. So what is so different about this document?
Well, Ileana, you know that there's nothing new in the world. Everything that's to be said has been said. We just felt it was needed to actually look at this again, because there were some very august definitions by some of the founding fathers of heart failure cardiology, but they weren't really practical in the sense that it wasn't very democratic. If you weren't a heart failure specialist, it was difficult to interpret parts of the definition, like the circulation was not adequate to supply the metabolic needs of the tissue at rest or on exercise. How would a bedside doctor be able to assess that? So we tried to make it usable by a number of specialities. Doctors who look after heart failure patients, but just want a sort of checklist to say, this is probably heart failure, this probably isn't.
What was your position in that paper about biomarkers, particularly the natriuretic peptides?
Yes, well, we thought, and I was pushing very hard, but a lot of us were, to raise the status of the natriuretic peptides, particularly N-terminal pro-BNP, probably, to becoming a very important part of the diagnosis. We chose not to go as far as to say that heart failure was elevated N-terminal pro-BNP on the setting of a clinical picture. We said it was one of the important ways you could document that it was heart failure. So we wanted signs and symptoms of heart failure, an objective abnormality of cardiac function, and supported by documentary evidence of congestion, which could be evidenced a number of ways, one of which was elevated N-terminal pro-BNP or other natriuretic peptides.
I think this group that has been listening to my podcast has heard me talk about the stages of heart failure as well. but I think that you guys took stage B, which used to be just, the heart doesn't look so hot, but the patient looks fine. And I think you've extended that. So what's different about stage B
Yeah,
now?
that was tricky. It was, I mean, without sort of telling stories out of school, it was one of the issues that was just slightly difficult to untangle because it was a difference across the pond, across the Atlantic between ACC, AHA, the stages of heart failure that goes back to risk factors, and the European perspective that heart failure was a symptomatic condition and that we didn't want to call just purely having a risk factor like hypertension being heart failure. It's a bit, I heard it expressed, it's a bit like saying a smoker has cancer.
Right.
So we ended up, which I think is a really good stage, to say that there's 4 stages of progression, and the first 2 are at risk for heart failure, which is risk factors, a good description. And the second one is pre-heart failure. And a number of conditions, we have this precondition. It means that there's already something happening that tells you that heart failure is going to happen unless you intervene.
And that you got to
And
do
then you've got,
something about it. We just wrote an editorial actually on the paper from the regulatory point of view.
oh, excellent.
And the interesting about the regulatory is that, we look at whatever comes in, on a protocol or on a study. And that's what we use because that's what whoever is, whether it's a drug, defining it. And so we don't have our own universal definition, but we take what the professional societies, et cetera. Now, the AHA and the ACC have completed the heart failure guidelines. They're out for review. Do you have any thoughts about were they going to agree with yours? I'm surprised it wasn't endorsed.
Yes.
And it's probably all political, but what do you think?
It's political. Well, as we all know, guidelines are sort of done shrouded in secrecy, quite appropriately. So the European, the HFA ESC guidelines is due to come out in September, but we actually had a first exposure of some of the recommendations around drug treatments at our recent meeting. And as part of that process, there were feelers put out as to what the American guidelines would say around definitions and whether the ejection fraction subtypes like heart failure with what we're now calling mildly reduced ejection fraction, because no one wanted to do something that was going the opposite direction to the other major grouping. So we just wanted to check there was comfort in numbers.
I mean, it's really been secrecy. We all suspect that the SGLT2s will be added to sort of the foundational therapies. I think that's, well, everybody kind of agrees.
Yeah, no, I think we're seeing that. The Canadians got in first, updates, the European guidelines, the bits that have been released have SGLT2 inhibitors or 2 named drugs up there as one of the 4 main foundational therapies. And the trend we're seeing is that it's no longer a rigid order, step 1, step 2, step 3, steps 4. It's a destination. You want all 4, and now let's talk about how you get there.
Right, and clinicians may have to pick their own pathway to get there, but getting to that goal, I think, is better saying it that way than, well, you have to up titrate. Well, I'm up titrating to what? And which one do I up titrate first? I mean, those have all been questions. Well, Andrew, thank you so much for sticking with us here and being my guest. It's always terrific. I want the audience to take a look at HFA. It's online. They're going to be able to see, register, and they can see some of the talks. And do read this universal definition of heart failure. I think you'll find it's very well written. It's very easy to read. I think you'll find it very helpful. So this is Ileana Piña signing off. Thank you for being with me today. Have a great day.